Okay, we are at the top of the hour. Welcome everyone to today's GlomCon seminar. Today's speaker is Dr. Andrew Lundquist.
All right. Well, thanks everybody for joining today, and thank you for the kind introduction and the opportunity to talk. Excited to be here. And so today's topic, we're going to discuss genetics in kidney disease. And so the title is Navigating the Genetics of Kidney Disease in 2025. So brief outline. In the first little bit of the talk, we'll give a bit of background on prevalence and categories of inherited CKD, as well as some potential indications for testing. But the majority of the talk today we'll spend on a few cases that bring up some of the complexities when we send genetic testing and how do we interpret those complexities. Here at the start, we'll just do a quick warm-up question to get everybody on the same page. And so this simple question: prior studies suggest that monogenic disorders may explain what percentage of adult chronic kidney disease? A, 0 to 5%, B, 50 to 60%, C, 10 to 20%, or D, greater than 80%. So we'll give another few seconds here. And I'm assuming everybody can see it in real time like I can, but the vast majority of folks are opting for option C, which is the correct statement based on what we are currently thinking in terms of the monogenic contribution of adult CKD is somewhere in the 10 to 20% range. And there we go. So this has been known for a while that there's a genetic component to the chronic kidney disease that we see over time. And this was a study or a paper by Engelfinger back in 2016. And she described congenital or chronic kidney disease due inherited components as one of the factors that contribute to CKD as we get older, along with acquired kidney disease, nephron number, or environmental or life challenges. But then a paper by Groupman et al. In the New England Journal back in 2019, this group from Columbia looked at a sequential group of patients in their clinic, over 3,000 patients, and did exome sequencing or genetic testing, and identified that they found a genetic component in about 10% of patients. And so this, was a seminal paper in the field of sort of inherited kidney disease, because it showed how common these patients are in our practice. And you can see from the distribution here, the majority might have cystic kidney disease, and a lot of times we know there's a genetic component, but there were a significant number of other cases found as well. And so not long after, a number of specialty clinics developed, and we developed one here at Mass General Hospital, looking specifically at patients with inherited kidney disease. And these clinics are often enriched for patients that may have a genetic component. And so you'll see in the literature that these specialty clinics often find a genetic cause in up to about 50% of patients that we're seeing in clinic. And that's what we saw in our clinic as well, and continue to see those patients that tend to have an increased likelihood of a genetic component. When you test these populations, about half of them test positive in our current testing platforms. And similarly, in our clinic here at Mass General, we found a similar distribution of types or categories of inherited kidney disease. In our first group, we found patients with the autosomal dominant tubular interstitial kidney disease, Alport's, various sort of tubulopathies, polycystic kidney disease, and then a variety of other less common phenotypes. So now we tend to break down the potential categories of inherited kidney disease into a variety of groups. And this was a recent review that was published in the New England Journal by Vivante, and it's a very thorough and good read if you haven't read it yet. And this figure just outlines some of the more common categories that we tend to think about in patients with inherited kidney disease, ranging from ciliopathies such as polycystic kidney disease, the podocytopathies, inherited forms of FSGS or various causes of proteinuria, the glomerular basement membrane such as Alport, the tubulopathies, which, autosomal dominant tubular interstitial kidney disease, or the Barter's or Gittleman's. And then kidney stones, as well as developmental abnormalities such as Kakut. And then finally, the atypical HUS, or the complement-mediated disorders. And these are sort of representative categories, but we do see other more rare forms as well that don't fit into some of these categories. So a lot of people often ask, what are the typical indications or the standard indications for considering genetic testing in chronic kidney disease? And I think these are slowly evolving over time, and we're using genetic testing more and more frequently in our practice. But I would say personally, if I come across a patient who has a form of chronic kidney disease that's not